Hi, everyone. Thanks for joining us tonight. Myself, Dr. Thomas Nabity, my partner, Dr. John Santa Anna, and we're here tonight to talk to you guys about knee problems and how we address and evaluate patients coming to us with knee pain. In order to kind of give it a little more of a real-world feel, we thought we'd present a case from a patient that we recently treated, and then just explain a little bit how we go about our evaluation and our thought process and figuring out the best treatment option for our patients. So I'll turn it over to Dr. Santana and let him go over the case example. And as always, when we do these webinars, feel free to chime in with your questions. We'll save lots of time for question and answer at the end.
Yep. Hi, good evening, everybody. Thanks for joining our webinar here. Dr. Nabit and I are really happy you guys are here to join us. We would like to talk about a topic that we think is very important in here in regenerative medicine. It's of all the things that we treat here at the Michigan Center of Regenerative Medicine, we treat knee pain primarily most of the time. It's the most common thing that we treat here, although we do treat other issues with other joints and spine as well. But anyway, on with the case. So I'll go over the case, and then we'll go over how we typically would see a consultation and kind of get a glimpse of how things go in the office. Okay. So the patient comes in the office. He's a 73-year-old male, really healthy. He comes in with complaints of knee pain. He's had the pain for about 15 years. Initially had a arthroscopic knee surgery. It's where he had his knees, quote unquote, cleaned out. Over the past few years, he said the pain has been progressively worsening. So he's a very active guy. He likes to play golf. He still likes to exercise at home. He uses his brace anytime he has to walk around and go do some stuff. He mentions that the pain is primarily intermittent, mostly with some activities. It's worse when he's going down the stairs or when he's getting up from a seated position. The pain is usually improved with heat or with medications and sometimes rest as well. He's tried other treatments. So he's tried physical therapy. He's tried rest before. He's had steroid injections. Most recently, he's tried hyaluronidase injections, which is the gel injections to kind of help lubricate the knees. Those last about a few months. He's coming in the office today because he doesn't want to get another knee surgery. He wants to see what his other options are. Past medical history, nothing really too significant other than the knee arthroscopy that's had 15 years ago. He does have high cholesterol and sinusitis. Both are well controlled with medications. He has no allergies. He drinks socially on the weekends. He does not smoke tobacco. His family history is non-contributory. So for somebody that comes into the office like this, Dr. Nabby, how would you first assess them, and how do you go over their case?
Yeah, I think it's a good place to pause. Yeah, the history. I mean, we chose this patient because this is a pretty typical history where we hear. So it's our knee osteoarthritis patients classically have had other treatments. They've tried things first. This isn't their first stop where they're having a new onset pain. So typically it's things that people have been managing with for quite a bit of time. And if they haven't done that, both Dr. Stanton and I will discuss those things at the consultation. So the kind of hallmarks that really speak towards this being a knee osteoarthritis patient are that aching pain, the pain at rest and with activity. Obviously the fact that he's had surgery before speaks to the fact that there's going to be some degenerative loss of wear and tear of the cartilage. A little bit about his past medical history. There are things that can preclude patients from getting stem cell procedures. Anyone with active infection and active cancer, we don't want to spread those diseases from one area of the body to the other. Other relative contraindications, things like blood thinners, people who have autoimmune disorders, in particular taking anti-immune modulating medicines. It doesn't mean they're not candidates, but it might be things we look at as far as reducing maybe the outcome that they might get from a procedure and making sure we're bringing that as part of the consultation.
Good. So for this physical examination, very classical for knee osteoarthritis. He is tender palpation primarily on the inside part of the knee. He has a little bit of swelling that goes on. He does mention that over time, when he's more active, he has more swelling in the knees. On this particular visit, he has a little bit of swelling and inflammation. He has grinding in his knees whenever you go through the full range of motion with his knees. Otherwise, his gait is normal. He's able to get up from a seated position well, but that's the only thing that's kind of popping up.
Yeah. So the things I look for on the physical exam, a big one is range of motion. So making sure people have good full range of motion. If they don't, it doesn't mean they're not good candidates, but that is something we oftentimes will see not improve with the type of regenerative medicine treatments we do. And the reason I explain that is that these cells and these injections are designed to regenerate tissues. They're designed to regrow things. And typically it's not the lack of cartilage that's preventing movement or losing range of motion, but it's a growth of bone called osteophytes that develop when you have arthritis and you have laxity in a joint. The joint doesn't like that. And so it tries to stop that movement. And one of the ways it can do that is by growing these osteophytes, or these calcium deposits that then can restrict movement. So that is an important part of a consultation. If a severe range of motion loss is necessary, I try to steer patients towards surgical in those conditions. Whereas if it's a minor range of motion loss, it's not necessarily restricting function. And particularly if it's pain that's limiting the function and it's pain relief that patients are looking for, those are really the best candidates. The physical exam is really to confirm that the suspected diagnosis is correct. So when we suspect a diagnosis on a history, we want to do a physical exam and use things like diagnostic imaging. In our office, almost everyone gets a diagnostic ultrasound as part of their consultation. This patient received a diagnostic ultrasound as well, and we could see wear and tear of his of his knee joint, in particular wear and tear of the meniscus, which is one of the cartilage structures on this patient. It's on the inside and outside of the knee, but on the inside of the knee on this patient, where it was really degenerative and macerated. I wouldn't call it a tear on this patient. Meniscus tears are things that we can treat, but he had a lot of meniscus degeneration and maceration, as well as cartilage loss on the end of his femur and on the cap of his tibia. So if you think of the knee joint as being a hinge, the lower leg, the tibia, and the femur come together, and there's a cartilage cap on the end of both of these called osteochondral cartilage or hyaline cartilage. And that's another type of cartilage we can assess well with ultrasound. And he had significant loss of that cartilage as well. Again, two findings that really just confirm the suspected diagnosis that he has osteoarthritis of the knee, and also confirm that he's a good candidate because he has good full range of motion. Then the last thing I'll say about the amount of cartilage that's left is that a lot of patients come in with X-ray diagnoses or have been told that they're bone on bone. And that's an important to distinguish between whether they're truly bone on bone or whether it's an X-ray finding that appears that they're bone on bone, but they do have some cartilage left. And the reason that's important is these cells need what we call a scaffold. They need a substrate. They need something to tell them what to become or what to grow. If we truly inject them into an area and there is no cartilage left, they won't know to become cartilage cells. They won't know to propagate or to start a regenerative process that's going to lead to added cartilage cells. So again, even if you've been told that you're bone on bone, it's worth an evaluation, either MRI or ultrasound, to really evaluate there are some cartilage cells left. But I think both Dr. Sand and I will attest to, we have had patients come in and they truly are bone on bone, and we tend to steer those patients away from regenerative procedures and towards surgical procedures because we want good outcomes for our patients.
I think that's the important part about the physical examination is that we get to determine which is the best treatment for the patient, right? So a patient like this, where he still has pretty good range of motion, he's still pretty active, he still has some cartilage in the knee, he's still essentially functional, kind of points that he would be a good candidate for stem cells or PRP or regenerative medicine that we offer. Somebody who is kind of later down the line who has had this issue and is more degenerative or has more severe arthritis in the knees, that may kind of steer the conversation a little bit away from regenerative medicine and more towards other treatments that we have for the knee, such as whether it's surgery or a peripheral nerve stimulator that helps with knee pain, or something like a nerve block in the knee to kind of help with function and activity. So there's other options that we can offer aside from regenerative medicine here in the office. And that's where we kind of think having a really good, thorough physical examination and a thorough history makes us determine the best treatment plan that we can recommend for our patients. With that being said, most patients are going to be candidates for regenerative medicine. The outcomes may be a little bit different from somebody who is early on with the degeneration versus somebody who's later on the degeneration. But we'd like to give all these treatment options and present them all to our patients. And from there, the patients can make an educated guess or an educated choice as far as what the best treatment outcome is going to be. So for this patient, Dr. Nabby, when you did see him, how did you counsel him, and what treatment he ended up choosing?
So, he came up after really exhausting his conservative treatment. So we didn't have much to discuss as far as further conservative treatments, non-surgical treatments. And so we really spent most of our time talking about the difference between his regenerative options. He had already seen his orthopedic surgeon. He knew that a knee replacement was his next surgical option. So in discussing for him the difference between a PRP procedure and what you can expect from a PRP procedure versus a stem cell procedure in our office, a bone marrow concentrate stem cell procedure. And given the fact that he had lost osteochondral cartilage, that's that hyaline cartilage, again, on the cap of the femur and the cap of the tibia, and as well as the amount of meniscal cartilage that he had lost, I felt that a bone marrow concentrate procedure was going to be more effective for him than a PRP. What I typically see in these situations is that patients with this severe of cartilage loss do better with the stem cell-based procedure rather than the PRP procedure. The major difference between the two, with a PRP procedure, you're injecting a signal, something to tell the body to send stem cells to the area. That signal is very concentrated, it's very loud, and in vascular areas with a good vascular supply, stem cells are able to mobilize and get to that structure very well. In structures that don't have a great vascular supply, things like the two cartilages we just talked about on the knee, the meniscus and the osteochondral or hyaline cartilage, those structures tend to do better with a stem cell procedure because we're actually going to get the cells and we're delivering them right there. They do bring other cells to the area, but by delivering the cells directly to the end structure, we're able to get more tissue growth in those hard to are avascular, poorly vascularized structures. So for this patient, we recommended a bone marrow procedure, and that's what we ended up going forward with.
Good. How did you do afterwards?
So I've had the follow up with him. It was his first follow up, so it's still early in the process. He had a fairly typical response in that he had pain during the procedure, shortly after the procedure, well controlled with the nitrous oxide laughing gas that we use here in the office. And then he was able to walk to his car after the procedure. I talked to him the day after the procedure. He was not taking any pain medications, using heat to kind of manage the pain. And then it returned to his normal pain within 3 days. At his 1 month follow-up, he was noticing some slight improvements in strength, decrease in the grinding kind of sensation, still having troubles going up and down stairs. And then at his most recent 3 month follow-up, he's able to resume to his golfing. He's walking long distances with his wife again without pain, going up and down stairs without pain. He's really focusing on strengthening his quads now, trying to build up some of that muscle atrophy that he had developed from having pain and favoring that knee for so long. His before and after ultrasounds look significantly different. We saw a 25% increase in the strip of his osteochondral cartilage, and about a 50% increase in the amount of his meniscal cartilage. So having those before and after pictures that mirror what people are feeling symptomatically, it's powerful testimony to the effectiveness of these treatments.
Yeah, it never ceases to amaze me how well these treatments work. You know, I've treated some patients who are more advanced in the degeneration that they have in the knee with the arthritis, and given the other options that we've given them with further injections versus spinal cord a peripheral nerve stimulator, or a nerve block, or a knee replacement, or regenerative medicine, most patients will gravitate towards regenerative medicine, and still never ceases to amaze me how well this works and how well the body heals. I think the other big advantage of regenerative medicine is that compared to traditional medical treatments where surgeries and invasive type treatments are involved, is that the recovery time is a lot faster. There's very little to minimal downtime. For me, like after I do my procedures for my patients, I give them about 2 weeks of restrictions. And with restrictions, I mean, no exercising, no running, no jumping, no squats, normal activities of walking around the house or standing, going up and down stairs. Your normal activities are fine. So there really isn't much restrictions to do other than anything too strenuous or exercises. So as far as somebody who's active, who has a lot of responsibilities and being able to kind of just function at home, that's a big thing for them as well, and remaining to be independent. So the other thing that we do too here at the Michigan Center of Regenerative Medicine is that we like to keep track of our patients and how they're doing. So one of the things that we do is we're actually involved in data biologics. It's a patient registry that's involved in the entire country. Essentially, it's clinics who are devoted to regenerative medicine and doing regenerative medicine the right way. What we do is we try and compile data from all our patients to try and see if we can kind of get some consensus on how patients respond to separate treatments. So we'll get a pretty good idea of how this patient in this demographic at this age who has these symptoms and receives this type of treatment, whether it's stem cells or PRP at this concentration, and this is their outcome after that. So the bigger our registry, the bigger our patient pool that we're able to accumulate nationwide and with other practitioners, I think it's a really powerful tool as far as seeing what potential outcomes and prognosis is that's actually based on real data.
Yeah, that's I think a key feature of what we're doing here that's really going to help us move this science forward. Tracking outcomes. The other thing that's going to help really move the science forward is giving a dose to our procedures. Another thing we do here at the Michigan Center of Regenerative Medicine is we will do a cell analysis on every sample before we inject. So when we do your bone marrow aspiration procedure, we'll get a baseline level, and then after processing, we'll give a post-processing cell count, which is essentially the dose of the stem cell procedure. So we know, and then can track whether specific doses do people do better.
Okay. So just a side question, Dr. Nabby, when you talk to patients about using PRP versus stem cells, how do you usually kind of decide which treatment or regenerative medicine treatment would you recommend to a patient?
Yeah, if I had to summarize the basic difference between the two, it's potency. So anytime that we need the most potent procedure possible is where I'll recommend a bone marrow. And those tend to be more advanced diseases or disorders of structures that have a lesser vascular supply, lesser blood supply. So examples are in the knee that we just discussed, as well as discs in the lumbar spine. Anytime we're talking about the joint structure inside a joint, the wear and tear of that cartilage inside a joint, I tend to recommend bone marrow versus structures like rotator cuffs, tendons, muscle tears, muscular-based neck or back pain, those things do very well with PRP. And the reason is they have a much better vascular supply. Age does come into play a little bit there. Younger patients do better with PRP. As we age, we tend to require the more potent procedure of bone marrow.
Yep. So I kind of do the same algorithm too. So when I advise patients as far as which is the better treatment option or what's a good treatment option for them, typically kind of similar to you, a lot of times just for a simplification, I tend to gravitate more towards PRP for less severe type of degeneration or non-weight bearing joints, tendons, ligaments, muscle tissue, things like that, where it would be effective in those types of things. For more high impact areas or weight bearing joints like knees and hips, ankles, spines, like you said, I tend to gravitate more towards recommending bone marrow stem cells. But again, age also comes into play. What are the goals of the treatment also comes into play. So a high level athlete, I'll probably recommend a higher dose of bone marrow versus PRP, depending on what the injury is. So again, all this everything is individualized based on the patient and what their presentation is. And hopefully we kind of come up with the best optimized solution for them.
Okay, it's a good transition. We have our first question. How important is age with this type of treatment? For instance, if I'm over 50, are my chances of recovery lessened?
That's a good question. We actually get that question a lot. So my answer to these types of things, it still works. So whether you're 20 years old or 91 or 92, it's still going to work. So I think the oldest patient I had was somebody who's in 91. The youngest patient I had was somebody who was 18. So your body's regenerative process is still going to work regardless of whether you're young or old. The number of your stem cells or your number of platelets, if it's PRP, is going to matter based on your age as well as your overall health. So obviously, the younger you are, the healthier you are, your regenerative process is going to be much better than somebody who is older and has other comorbidities. Now, that doesn't mean to say that somebody who's older getting a regenerative medicine treatment is not going to be effective for them. It just means that sometimes the goals of treatments are a little bit different for those types of age groups. Somebody who is younger in their 20s, the regenerative process is a lot better, but then their demands and their goals of treatment are also higher. So it kind of correlates with that. Somebody who's a little bit older might not have similar, they usually won't have a high level of activity like running marathons or triathlons or trying a new sport or something like that. The goals are a little bit different for somebody in that age group or age bracket. And the regenerative medicine still works. The other thing that I think that also comes into play with the age is and how we do our process, because we have the ability to actually count our cells. So we're able to see how much platelets are in your PRP, how much mesenchymal stem cells are going to be present in your bone marrow aspirate. So we're able to kind of look at these numbers and make a determination on whether is it going to be sufficient in order to achieve the goal that we're trying to treat. Are we trying to, and then if it's not enough, because let's say you're older or you have some other comorbidities, we can always go back to the source, which is you, and get more blood for your platelets or get more bone marrow for your stem cells. So we have that ability by actually knowing what we're going to inject in you to be able to evaluate if this is going to be effective. What are your thoughts?
Yeah, no, I couldn't agree more. I don't want to say the exact same thing that you just said, because I pretty much agree with everything you said. It's more about health than it is age. Age is a number based on chronologic time that you've been on Earth. It's not really a biological representation of how healthy you are. So just like responding to any surgical procedure, whether you're getting a heart procedure or you're having, a hip replaced or any surgical procedure, the chances of you surviving and doing well from that surgical procedure are more based on your overall general health than your age. So I think people focus too much on age. Oh, I'm too old for that. That's not necessarily true. If you're still regenerating your skin, when you cut yourself, if you're still healing that cut in a relatively normal time, you're regenerating. You'd be a good candidate. You have good regenerative cells. What we're doing is we're just taking those cells, concentrating them, and then using our skills as interventional pain doctors to deliver them directly where they need to go, and then stimulating growth and healing in that structure that we want to.
There's another question from the crowd here. Are there stretching exercises that help with knee pain? Foam rollers, fascia blasting, leg stretches, etc.
Yeah. So without a doubt, yes. These are parts of the things that we talk to people about as part of the consultation. Both Dr. Santana and I are both board certified physical medicine and rehab specialists, physiatrists. That's all part of the things that we talk to people about. And a lot of those things that are referenced here, things like foam rollers, and the fascia blasting, the cold laser therapies, the percutaneous massagers, those are traumatic in a way that it stimulates growth and healing. They are regenerative. They're just to a lesser potency than a stem cell or a PRP procedure. But that's all stuff that we incorporate into our rehab programs, whether it's before or after your regenerative procedure. So our typical timeline for follow-up is we do a 1 month phone call just to see how you're doing, to go over what that regenerative process is going to be, and then a 3 month in office. But at that 1 month phone call, we spend a decent amount of time talking about the rehab process, what to do next, how to start using things like these stretching and other exercises that you can do to stimulate growth and healing, in addition to the regenerative injection that we just did for you.
I agree. And this is what I always talk to patients about, that whenever I get a consult from a patient with regenerative medicine, I tell them that the easy part is the injection part. That's my job. My job is the easy part. I just inject the structure. We do a sniper shot at the structures that we need to go. The hard part is what you do after we do the injection. So the range of motion right after the treatment, adhering to the limitations post-treatment, and stopping yourself from doing too much and gradually progressing with your rehab, and also adhering to the rehab program. So sticking with a slow, progressive, deliberate progression of activity to return to play is probably the most important part of all this. Everything else that we're going to do in the beginning is just the beginning.
I got another question here. I've had a knee replaced and I'm still having knee pain. Is there anything that you can do for me?
We get that question a lot too. So if it's a knee replacement, unfortunately, you have a prosthesis where your knee joint used to be. So unfortunately, regenerative medicine is not going to be the best option for that kind of treatment. What we have found, though, based off of our sports medicine interventional pain training, is there are different treatments that we do that can help with knee pain post-surgically. So one of the options that we could do is doing nerve blocks into the knee. So there are nerves that give sensation to the knee joint. Sometimes when we do nerve blocks on those nerves, we're able to block that sensation of pain coming from that artificial knee. We follow that up with a nerve ablation, which actually we burn off the nerves, and therefore it kind of gives you like a long relief of pain, typically about 8 months to a year of pain relief. And then if needed, we can always redo that same nerve ablation again. Another step more to that, that we're doing more here in the office, have found really good efficacy and better return of function for our patients, is doing called a peripheral nerve stimulator. So going by that same premise that you still have these nerves that give sensation to your knee joint, we're able to put a very thin wire, which is essentially a very thin piece of wire, which is the implant, right along the nerve that gives sensation of pain to your knee. And we're able to block those pain signals by controlling the electrical impulses that your nerve gives with the sensation of pain. So with this device that's implanted in you, you are able to control how much pain sensation you're going to feel in that particular area. in return, you're able to perform more. You'll have a better function, and have a better outcome from having your knee replacement and having that prosthesis and being able to return back to function.
Yeah, those same things. I have seen some cases where it was thought to be soft tissue causing the pain. Medially, like kind of a scar tissue, tighter ligament post-surgery, and injecting with PRP, we got some relief from that. But if it's hardware loosening, if it's in the bone, like a bone marrow edema from the seed of the implant, the nerve ablation and the nerve stimulating procedures Dr. Santana reference would be my recommendation as well. Yeah.
I actually had a patient before too. It's kind of an interesting case. So he just had a total knee replacement as well. A younger guy had a total knee replacement. He's really he wants to get back to activity. He's really throwing himself with the rehabilitation and physical therapy, but he just couldn't get his full a good enough range of motion when bending his knee with a prosthesis. So he was referred to me by an orthopedic surgeon to try and see what we could do as far as relieving some of his pain so he can get his range of motion back in his knee. Because from what the surgeon is able to see, the hardware looks great. Everything should be working fine, but he's just having that endpoint pain that he can't get passed through. So we ended up doing the nerve block followed by the nerve ablation, and he responded really well. Now he's able to get full range of motion more now after we did the nerve block. So just getting him over that hump of pain when he's doing his activities and therapy definitely got him to be improved much better. So that's the other things that I think, gives us an advantage over other physicians and practitioners who do regenerative medicine too, is that this is our field. We do regenerative medicine, but we also do pain management. We also do sports medicine, and we're very familiar with these types of cases, and we have a lot of tools in our toolbox that we can present to our patients. And that's what we bring to the community, and hopefully we can help, a lot of people like you.
We wanted to try to keep this to around a half hour. We're kind of close on that. It looks like we have one more question. Maybe we'll do one last question. I have meniscus tears and have been recommended a meniscectomy. Is that anything that you can help with?
So meniscus tears actually respond really well to PRP. So it's rolling it back a little bit. So meniscectomy means that the surgeon is going to go in there and actually cut off a piece of your meniscus. What's the role of the meniscus? The meniscus acts as another kind of padding and cushion into the knee. So when you cut off a piece of that, over time it is going to progress to degeneration, arthritis of your knee joint. We've found some good outcomes doing PRP and even stem cell regenerative treatments into the knee by injecting right into the meniscus. It's shown that it has a good outcome compared to what the surgical outcome would be for a meniscectomy. Regenerative medicine kind of gives you that idea of, instead of taking the piece away, you're actually trying to rebuild and add that piece back on. So if somebody comes in with a meniscus tear, I always recommend to try regenerative medicine over surgical options if we can.
Yeah, it's one of our quote unquote home run cases with PRP. It just works extremely well. If it's a clear meniscus tear without a big extrusion, those are home runs. If there's some extruding meniscus and it's starting to really put pressure on the outside, the ligament it pushes on, it's the medial collateral ligament. We'll inject that ligament. We'll try to get it to push back in. The extrusions sometimes don't respond as well as the clear tears. The tears are, they do, extremely well.
Yeah. All right.
I think we can probably safely wrap this one up. We appreciate everyone that tuned in and signed up. We will send out a replay if you can think of anyone that might benefit from some of the things we discussed here. By all means, please share it with whoever you think might be able to benefit from this information. And if you'd like to set up, we do telemedicine consults. We do inpatient consults. If it's something you think that you might be interested in learning more, feel free to reach out to us. I'm sure our email, or rather our website, is readily available to you, but it's regenerativemedicinemichigan.com, and phone number 248-216-1008. Both myself, Dr. Tom Navity, Dr. John Santana, be happy to try to give you help.
All right. Thanks again for tuning in, everyone, and good night.
All right. Good night, everyone.